This is Dermatology Weekly, where we bring you interviews with leaders in the field of dermatology and the latest news in dermatology. I'm the voice of MD Edge Podcasts, Nick Andrews. In episode 79 of Dermatology Weekly, we are taking a break from new content and encourage all of you to enjoy your Labor Day holiday. We hope you have a happy and safe 3-day weekend if you have one, but if you don't, stick around because we've got the best of our resident takeovers, 3 different editions of the resident takeover for you in this episode. Don't forget, you can email the show at podcasts@mdedge.com, and you can follow us on Twitter at mdedgederm. And for your information, things we've got coming up include discussions about COVID restrictions being loosened and people making it back to dermatology clinics and a bunch more. Got a big fall planned for you here. So we count down the top downloaded resident interviews of Dermatology Weekly in the year 2020. So far this year, there have been a variety of topics affecting residents that have been covered, from the impact of training during COVID-19 to the use of low-dose naltrexone for over-the-counter topicals in dermatology and Muir-Torre syndrome. But we begin this best of episode with dermatology residency during a pandemic, which is from episode 73. You can find that link in the show notes. In this one, Dr. Candace Heath talks to 3 dermatology residents who are Dr. Brittany Oliver, Dr. Sophie Greenberg, and of course, Dr. Julie Crowley about their experiences navigating through dermatology residence during a pandemic.
Well, of course, this series is entitled COVID Conversations. So COVID-19 has really changed the lives of everyone in medicine. In fact, it's changed the lives of everyone across the country and even the world, if you really think about it. So uniquely, you all have had the opportunity to go through a pandemic while also being in the middle of your dermatology training. Yep. So I know that you have lots of things to share, and we cannot wait to hear about your experiences. But, being a dermatology resident, what happened? Were there other things that you started to do that were COVID related and not necessarily what you were doing beforehand? Did anyone have any specific COVID experience, like whether you had to work in the ER or you had to call people back, or what did your departments and hospitals have you doing? Brittany, do you have any examples of that?
Yeah, so while I certainly know residents that were pulled from their derm-related duties to work as part of their institution's actual COVID-19 unit, like very hands-on direct patient care with COVID-positive patients, I was never in that sort of situation, never on the ED floors or ICUs, but as cases were rising and my institution was preparing for a surge, new services were created to help evaluate and manage COVID-positive patients. So to fill the surge needs at my hospital, my co-residents and I, and actually the faculty as well, kind of filled the role of results management. So
results management.
Mm-hmm.
Tell us results management. Tell us about, we as dermatologists, we do a lot of procedures, which means that our patients need to be notified. So how did you take that skill and turn it into something that was helpful for the COVID community?
So basically, hundreds of results, positive, negative, indeterminate, were coming into our hospital system. And our department was in large part responsible for delivering those results. And it's not just about telling someone that they're COVID positive. It's explaining to them what that means, how this affects people living under the same roof as they are. How do they protect their family members? How long do they self-isolate for? It involved triaging based on their individual risk factors and what symptoms they were having into low, moderate, and high risk categories. So really risk stratifying. And this is all taking place on the phone as a dermatology resident who's usually doing, very derm specific sorts of counseling. And now suddenly I'm telling people counseling on what they should do if they feel short of breath or lightheaded or if they're coughing blood. So it's one of those things where we had to train for the role. But we all had, a year of internal medicine training that we could fall back on too. And it was very different. It was out of our comfort zone, but I think it really delivered a service that was necessary at the time. It was very, very large volumes of results coming through. So it was a role that needed to be filled, and it was a piece that we could contribute to fairly easily. I think we pivoted into the role seamlessly.
And let's go to Sophie next. I'm curious, you were really at the epicenter of all of this. So I'm curious to find out, what did you do? What was your role?
So I was in New York, which was the first city to have a high peak of cases. And so for the month of April, I, along with several of my dermatology co-residents, spent a month volunteering in the internal medicine department. I was on a hospital floor unit for most of the month, managing primarily COVID-19 patients. And I spent a few days at the end in the ICU. And my role was sort of a hybrid between the intern and the resident, where you were doing a lot of the floor work, but also you did a similar role to a resident as well. So yeah, it was definitely different than regular dermatology residency.
Oh, absolutely. And were you nervous about going back and doing that type of medicine?
That's a good question. I felt prepared for my intern year. I had a really awesome intern year. Shout out to CPMC in San Francisco, which prepared me really well for this role. And I had a lot of support. I had friends in the medicine department and I made new friends. So I felt very comfortable to ask questions and to get consultants and just really felt supported throughout the whole time.
Oh, wonderful. That's great. And you may not realize this, but I've also worked in the COVID unit of my hospital as well. So I can definitely identify with that. All of the emotions. But overall, didn't it feel rewarding to give back in that way?
It was so rewarding, and I was really anxious to get in and help, hearing about all of the stories of exhausted physicians and patients who needed care. So I really felt called to be in there in the center of it, and I'm really happy that I could give back in that way.
Oh, wonderful. I'm sure you have memories forever. And Julie, what about you?
Yeah, so my hat goes off to you guys. I am so proud of my dermatology colleagues in those cities hit harder by COVID than my city. So I've had a little bit of a different experience. I'm down here in Galveston, Texas. So at the peak of the COVID cases up north, we really weren't hit too hard. We were in lockdown like everybody else, like end of March, all through April, but we really didn't have that many cases here. I think we were well under 100 cases through the whole lockdown.
Oh, wow.
The dermatology residents, our residents were tiered at our hospital. And so we were ready to be pulled if that was the case, but we really didn't have the need. So when everything opened up, I think people got a little bit comfortable given that we didn't have a lot of cases. And so we really just reached our largest numbers, Texas, this week. And we're kind of on a dangerous trend upward. So I think, we're trying to learn a lot from how things were handled up north. This was the first week our dermatology department actually was pulled. We started having people pulled to the COVID floors. So this week we only had one faculty and one resident pulled. And so we're hoping that the cases kind of even out, but that's not really the way the trend is going right now. So yeah, like I said, our role has been very minimal in the COVID units. We're here and we're 100% ready to help out, but there hasn't been that need here yet. And so I'm hoping it stays that way just for the community's sake.
Remember, you can find a link to the original episode in which that interview happened in the show notes. Okay, we move now to a clip from episode 52, which features Dr. Daniel Mazori speaking with Dr. Nadine Shabeeb about the benefits of off-label, low-dose naltrexone for the treatment of inflammatory skin conditions.
What naltrexone is and how its off-label use in dermatology compares to its approved indication.
Yeah, so naltrexone is an opioid receptor antagonist, and it's approved by the FDA to treat addiction to alcohol, opiates, and heroin. The dose to treat addiction is 50 to 100 milligrams per day, and at that dose, it blocks opioid effects for 24 hours. But the dosing for low-dose naltrexone is a lot lower, and that's between 1.5 and 4.5 milligrams per day. At this dose, naltrexone only binds partially to the opioid receptors. So this ends up leading to a temporary opioid blockade and ultimately increases endogenous endorphins. Low-dose naltrexone, which you might hear me refer to as LDN, its anti-inflammatory effects are by blocking non-opioid receptors. So naltrexone blocks toll-like receptor 4, which is on keratinocytes and macrophages, and these macrophages contain inflammatory compounds like tumor necrosis factor alpha or TNF-alpha and interleukin-6. So ultimately, low-dose naltrexone can suppress these inflammatory markers, which is how it works in some inflammatory skin conditions. And these anti-inflammatory effects aren't seen at the higher doses of naltrexone. They're only seen at the lower dose.
That's really interesting, and it makes me curious about how these dermatologic benefits and anti-inflammatory effects were first discovered. Do you know how dermatologists first came to think about low-dose naltrexone?
Yeah, so in October of 2017, there were a couple of case series that were published in JAMA Dermatology, and each one covered a few patients with Hailey-Hailey disease that were treated with LDN. In one of them, they noted that patients had discussed LDN on social media platforms like YouTube, but that there hadn't previously been any published evidence for it.
In addition to case reports on Hailey-Hailey disease, do you know what other dermatologic conditions have been reported to benefit from low-dose naltrexone and what the level of evidence is for these conditions?
So at this point, the level of evidence is mostly case series and case reports. And some of the other conditions, aside from Hailey-Hailey, include lichen planopilaris, psoriasis, and then also various causes of pruritus as well.
At my program, one of my attendings has used low-dose naltrexone for pruritus that's idiopathic. What's been your experience treating any of the conditions you mentioned or any others with low-dose naltrexone?
So at our institution, one of our faculty, Dr. Apple Bodemer, is fellowship trained in integrative medicine, and so she really commonly prescribes low-dose naltrexone, as do some of our other faculty. So some of the commonly treated diagnoses include psoriasis and lichen planopilaris. Also, in some other conditions that we use LDN for include pruritus that has had a negative laboratory workup, that's failed topical treatments, and other systemic treatments, for example, like phototherapy. I've also seen it used in patients who have had negative patch testing but still complain of pruritus or of a burning sensation without really a clear underlying cause. Finally, we also use LDN as a treatment option in patients that have contraindications to other systemic anti-inflammatory treatments. So, for example, in a patient with a history of malignancy, we would want to avoid a biologic agent. Or in a patient with a history of high cholesterol levels, we may want to avoid acitretin.
So it seems like the underlying conditions where low-dose naltrexone seems to be used have some kind of either pruritic component or inflammatory component, and maybe a kind of special area where it comes into play is in patients who have contraindications to on-label treatments for those conditions.
Yeah, I think that's exactly right.
And that, of course, from episode 52. You can find a link to it in the show notes. We move now to episode 65, featuring Dr. Daniel Mazori and Dr. Sophie Greenberg about the selection of over-the-counter topicals to avoid potential adverse effects. Dr. Greenberg and Dr. Mazori discuss how the U.S. FDA categorizes and regulates over-the-counter products, as well as different resources that they know about to learn more about common ingredients of over-the-counter topicals.
Something that was interesting to me that you wrote about in your column was how incorrectly selected OTC products can cause or exacerbate a skin condition or even result in systemic toxicity. So I was wondering if you've seen any adverse events in your patients from over-the-counter products.
I definitely have. We see a lot of allergic contact dermatitis, which is an allergic reaction to ingredients in topical products. I often see eczema exacerbated by incorrect selection of topical products, like the wrong type of moisturizer or choosing an irritating product, and acne that's exacerbated by choosing comedogenic topicals.
Yeah, those are really good examples. I think whenever you see an acne patient, going over all the products that can be comedogenic versus non-comedogenic, and sometimes can be very time consuming because there's so much out there and it's hard to decipher and go through all of that. So I've definitely seen that in my patients too. And certainly allergic contact dermatitis as well. I don't think I realized before dermatology residency how certain topical antibiotics can really bring that out in patients. So that's something that I always try to counsel my patients about.
Yeah, that's a really good point too.
Something I didn't know about before reading your column is how the FDA categorizes over-the-counter products, with each category subject to a unique set of regulations. What categories are relevant to dermatologists?
Yeah, it's a little confusing how they regulate it, but I would say the four major relevant categories are drugs, which includes both prescription and non-prescription medications. The second one would be cosmetics. Third is soap, which is a category all by itself. And fourth is dietary supplements.
Yeah, I found it really interesting how soap is its own category. But I guess before we dive into that, since you mentioned drugs first, what over-the-counter products fall into the drug category, and how is this category regulated?
So drugs include things like topical steroids, antibiotic ointments, acne treatments, antifungals, and sunscreens. And most of these products were previously available by prescription only, but became available over the counter after sufficient post-marketing safety information. So once a company applies for their drug to become available over the counter and it becomes accepted as over the counter, the monitoring relies on reporting from healthcare professionals.
Do you know if the FDA is currently reevaluating how it regulates any products in this drug category when it comes to over-the-counter?
Yeah, so a big area in flux is how chemical sunscreens are regulated, which is in light of data demonstrating serum levels of these chemicals in humans above the FDA limit for drugs that are exempt from further testing for carcinogenicity, reproductive, and developmental effects. So I think in the coming months to years, regulation of chemical sunscreen will change.
Yeah, so we'll have to stay tuned as far as that goes.
Yeah.
The second category that you mentioned is cosmetics. Can you tell us what products fall into this category and how they're regulated?
Yes, so cosmetics includes moisturizers, cleansing shampoos, deodorant, makeup, perfume, and hair coloring agents. The FDA prohibits use of 11 categories of ingredients in all cosmetics. They encourage manufacturers to perform safety testing and have the legal authority to inspect facilities, but does not require approval, testing, or disclosure of safety data prior to products going to market. A lot of patients and lay public have expressed concerns over the safety of over-the-counter products, especially since regulation varies across the world.
Yeah, I can see how that could be concerning to consumers. And another layer to the cosmetic category would be imported cosmetics. So do you know if the FDA regulates imported cosmetics and if there have been any specific issues with these products?
Yes, so they do have the authority to regulate these imported products, but how this enforced is less clear. There have been cases of mercury poisoning from bleaching creams imported from Mexico, resulting in catastrophic neurologic damage for several patients, mostly in California. Clobetasol has been reported in products sold over the counter in the US, and I've actually seen this myself both in clinical practice. I've had patients with horrible adverse cutaneous effects from improper use of these products. And I have found these products on the shelves here in New York City, which I did report to the FDA.
Wow, good for you. That's really scary. Fortunately, I haven't seen anything as catastrophic as the neurologic damage that you mentioned being reported. But like you, I've seen patients who have had cutaneous side effects from bleaching creams that contain clobetasol and coming in with uneven skin tone as a result, or atrophy, stretch marks, telangiectasias. So I think that it's really important to be vigilant about that and educate our patients.
Yeah, I agree, because when we prescribe it, we have a chance to counsel patients on how to properly use these, but the fact that people can purchase them over the counter is very scary.
Yeah, I can think of a couple of patients of mine who unknowingly were using clobetasol with outbreak for years on end on their face, for example, which is a part of the body that we would even think twice about putting clobetasol on at all, depending on the clinical context, and likely never for years without breaks. So it's really a big, scary world when, these things aren't as regulated as we would like them to be, even if we're the ones as prescribers regulating them.
I know, it's horrible, and that changes their life to have something like that on their face.
And we wrap up the Best of Dermatology Weekly with a clip from episode 61 featuring Dr. Daniel Mazori, once again, one of our hosts of the Resident Takeover editions. He spoke with Dr. Mohammed Dany about the pathogenesis of MTS and its associated malignancies. They also reviewed diagnostic clues and tools for dermatologists when treating patients with solitary sebaceous tumors.
So I wanted to get started with the basics. What is Muir-Torre syndrome?
Muir-Torre syndrome is a rare genetic syndrome. It's inherited in an autosomal dominant fashion, and it predisposes patients to both cutaneous neoplasms and visceral malignancies. It was first described by Muir, clinician, in 1967, and then was described independently by another clinician called Torre in 1968. And they both described the same syndrome in a series of patients who have at least one skin sebaceous tumor and one visceral malignancy. And so now we refer to it as Muir-Torre syndrome. Some clinicians also refer to it as the skin variant of Lynch syndrome, which is also known as hereditary non-polyposis colorectal cancer, because they both have similar pathogenic etiology.
And what are the cutaneous neoplasms that are associated with Muir-Torre syndrome? I know you mentioned sebaceous tumors. If you could talk a little bit more about those and any other cutaneous neoplasms that these patients may get.
So really, sebaceous tumors, again, are the hallmark of Muir-Torre syndrome. So while as dermatologists we see sebaceous hyperplasia all the time, we do not encounter sebaceous tumors that often, as they are rare outside the context of Muir-Torre syndrome. All three types of sebaceous tumors can be present in these patients: the adenomas, the epitheliomas, and the carcinomas. That being said, non-sebaceous skin tumors can also develop in Muir-Torre syndrome, especially rapidly growing keratoacanthomas and basal cell carcinomas. But usually also the basal cell carcinomas have some sort of a sebaceous differentiation.
And I know you also mentioned visceral neoplasms being a part of Muir-Torre syndrome. Can you speak to what visceral neoplasms are associated?
Yeah, so that's a great question, because this is where, as dermatologists, we can make a difference in the management of these patients. We are the ones who usually make the diagnosis, and we should know that these patients are at risk for developing several visceral malignancies and thus require screening. So most commonly, those patients develop colorectal cancers, especially in the proximal part of the colon. They can also develop endometrial cancers, ovarian cancers, breast, lung, genitourinary, hepatobiliary, hematopoietic, and central nervous system malignancies like glioblastomas.
So with those malignancies in mind, what is the type of screening that patients with Muir-Torre syndrome should be undergoing?
Yeah, so this is really a multidisciplinary management. And just because I'm biased, I'll start by saying that every Muir-Torre syndrome patient should definitely see a dermatologist at least once a year for skin cancer screening. So that's number one. And then for the rest, they should have annual neurologic examinations by their primary care doctor, just to make sure they're not developing any brain tumors or symptoms of that. And then testing-wise, they should start colonoscopies at the age of 18 years if we diagnosed it before the age of 18 or at the age of diagnosis. So if we diagnose them at 50, they start colonoscopies at 50. If earlier, they start earlier. And then female patients should have annual mammograms and pelvic ultrasounds. And all patients should get annual CBCs with DIPs to check for hematopoietic problems, and then urinalysis to screen for GU tumors.
And that's a wrap on this best of edition of Dermatology Weekly. I am the voice of MD Edge Podcasts, Nick Andrews. Dermatology Weekly is produced by MD Edge editors Elizabeth Meshkati and Melissa Sears. All of our podcasts are produced by MD Edge executive editor and the senior vice president for Medscape editorial, Dr. Ivan Aransky. I host the show. I also edit it and audio engineer it. You're listening to Dermatology Weekly by MD Edge.